Now I am going to present a case scenario. This is a case of 48-year-old male who was a known diabetic of 5 years, admitted with history of abdominal pain, vomiting, 3 days duration. On examination, patient was dehydrated, tachypneic, BP was 110/60, there was a tachycardia, there is a respiratory 26 increased, CPG was 346, HbA1c was 11.2, serum the potassium was 3.1, sodium pH was 7.3. There is no question about the diagnosis, is diabetic ketosis. The question is only the potassium. How to proceed this? There is a diabetic ketoacidosis, the patient uncontrolled diabetes present with DKA. There is no question about diagnosis. Now potassium 1.3. The contraindication for IV insulin is potassium, hypercalcemia. If potassium is less than 3.3, that is a contraindication for IV insulin, because the insulin increases the potassium entry earlier than the sodium glucose entry. So as you give IV insulin, the potassium goes enter and fetal hypokalemia may there and fetal arrhythmia and patient may die of arrhythmia. So the patient was treated with IV fluids.
Paranthaman,
yes, sir?
Just for the sake of audience, I think your point is well taken. See, in the case of diabetic ketoacidosis, what happens is, because to maintain the electroneutrality, for balancing the acidosis, for the hydrogen that get into the cell, the potassium comes out. So even if a patient is severely potassium deficient, in a patient with severe DKA, pH of 7.1 or so, the potassium could be 5.8. Still the patient is potassium deficient. Only thing is, you wait for the potassium correction till you normalize the blood sugar level, the renal part of it is taken care of. So this is the other scenario that Paranthaman is highlighting. Here, you should not delay the administration of insulin and the fluids, but only thing is, you should be aggressive enough to supplement the potassium at the earliest. Normally we say about 20 milliequivalents per liter of the fluid or something like that. You have a protocol. When the potassium is less, certainly you can enhance after ensuring that the renal parameters are okay. And in your case, I think it was 3.6 or 3.4 if you remember, right? What was the potassium?
Patient 3.1, sir. 3.1. The patient abdominal pain, vomiting 3 days. Vomiting.
Use the term insulin is contraindicated. What I will say is fluid replacement takes precedence.
It's clearly described in the textbook of Harrison.
I cannot say contraindicated. Probably you wait for the nephrons to open up, replace the fluid and then think about...
that's correct. That's a point of interest is here. It's clearly mentioned in the textbooks that you should not be aggressive. It is contraindicated because it is fetal hypokalemia and arrhythmia, patient will die. That's the message here. So that's why, yes, sir.
Yes. Sir, the important thing is that the actual body potassium is probably much lower here. So at a pH of 7.3 and a K of 3.1, the total body, the excessive potassium is probably the true potassium is around 2.6, 2.8, and there it is actually an issue. So, but the thing is that you really want to be. So what you don't want to do is to do a loading dose on this patient. That's all.
Yes.
You can start the insulin, but you don't want to load. That's all it is. The opposite is also true. Remember though that when do you not administer potassium? So for example, a lot of times empirically we start potassium along with the fluids. The only time you don't want to do it is if the patient is anuric. Every other place you could go ahead and load the patient with potassium, nothing will happen because the potassium that is in the, what you're seeing in the potassium is actually a falsely elevated potassium. It will be much, much lower.
Yes, sir.
The only contraindication for pushing the potassium is if the patient is anuric. You wait till the urine output is established and then you push the potassium, nothing will happen.
Yes, sir.
There were quite a few papers against GIK as a routine this thing also.
I'm also against GIK.
Yes.
Yes, sir.
Not GBK though.
So this patient was treated.
So, and again, another point, in fact, I'm sure you have done a lot of literature work. If you look at the books of medicine, they'll give a quantitative assessment. For every 0.1% drop in the pH, the serum potassium can go up by 0.5. So that potassium of 5.2 might look ominous to you. But if it is in the context of 7.1 pH, the patient is grossly potassium deficient in spite of 5.2.
Yes, sir. It's true. Observed it, sir. So patient was treated as per the recommendation, hypoglycemia is corrected, then IV insulin started, and second day everything normalized, acetone became negative, serum potassium was 3.9, random blood shows 180. On third day, patient clinically improved, everything is all right, but the mild abdominal pain persists. but because the third day we started oral fluids. After starting oral fluids, again the abdominal pain started
Can
crying
we
up.
stop here and then have some interaction, Paranthaman?
Yes,
Because
sir.
I was about to ask you.
Yes, yes.
In fact, if you remember, some of us, my junior colleagues are here. If you remember, whenever you talk about DKA, the older textbooks of diabetes always used to say, patient presents with abdominal pain and vomiting. Is it an intra-abdominal pathology that has triggered the ketoacidosis, or is the abdominal pain because of the ketoacidosis with the hyperglucogonemia and mild dysmotility? So one point that was suggested, which was very, very fundamental, is the history. If the patient starts with vomiting and the pain comes later, probably it is DKA. If the abdominal pain starts first, most probably it's a pancreatitis or intra-abdominal pathology that is responsible. I think this was the background information
Yes,
that
sir.
I shared with you. Yeah.
That's all. So 40 to 70% of the patients with DKA will have abdominal pain. Usually upper abdomen is poorly localized, attributed to the gastric distension, stretching of the capsule, some inflammation of the pancreas. But here the patient continue to have pain. That means you have to search for the other cause. Like we thought of pancreatitis, having suspected pancreatitis, we have done a serum amylase within normal limit. Now what to do now? When you measure pancreatitis, serum amylase, the serum amylase measurement may be suppressed by high triglycerides. If you have high triglycerides, it will interfere with the measurement of the amylase and lipase. Thereby, you should do triglyceride before you sure that the amylase is within normal limit. So, hence, we thought that we have done of course triglyceride level. It was only through 260. To say the pancreatitis is caused by triglyceride, there should be a minimum of, usually it be more than 1000 milligram percent of triglycerides necessary to cause a pancreatitis, because it's a large molecule. Along with the triglycerides and chylomicrons obstruct the capillaries of the pancreas and can cause a necrosis and the tissue lysis. So in that case it was done. It was only 260. So it is unlikely. The patient continued to have abdominal pain. So we thought of alternate diagnosis, hypercalcemia. So hypercalcemia can have abdominal pain and vomiting, nausea, all this is similar presentation and along with the diabetic ketoacidosis, but the serum potassium, our patient the calcium was 8.9. Whereas if you have a calcium different variety, there may be serum levels, gastric ulcer may be gastrin, and this may be, if it's more than 12.8, it is a tissue calcification. If more than 4.8, it can cause fatal cardiac arrest and coma. But our case, it was normal. So we thought it may be a gastric ulcer. That may be the cause for the pain in a patient with the DKA, and endoscopy was done, again normal. So other cause also we wanted to rule out because the patient continued to have pain. So gallstone, renal stone, pyelonephritis, cystitis, everything was ruled out by ultrasonography. Then considering the possibility of, because the abdominal pain increases following food, we suspect the possibility of superior mesenteric artery occlusion. So we suspected, and then we did a CT scan. The CT scan showed that there is a ischemia over there, and there is a not a necrosis, there is a paper-like thinning of the small intestine. This is called abdominal angina. That is a superior mesenteric artery occlusion, and this was detected. Usually it is common in elderly. The abdominal pain. Sorry for the overlap of these things. And usually the symptoms will be disproportionate to the signs. There will not be any signs, but the symptoms will be severe. That's why the patient continues to have pain, severe pain, despite the other parameters are normal, elevated. And the patient is more common in elderly. 80 to 80, embolism is 80%, but thrombosis is 20%. It is associated with a high mortality if you don't recognize it and treat it. So hence, and the imaging you do, previously used to do SME, that is digital subtraction angiography, but it's not required. CT angio with the contrast is sufficient. That has replaced the gold standard test. Hence, we have done it. And thrombosis can occur. Apart from this, why this patient developed superior vena cava thrombosis? Because is a diabetes per se or something else. So diabetes per se can cause superior vena cava obstruction or by causing thrombosis, because it is endothelial loss, the destruction, oxidative stress to endothelium and loss of endothelial glycocalyx, which is the one which produces anticoagulants. If anticoagulants is less, and also it increases the production of plasminogen activator inhibitor. So increase the coagulation, and by this we thought it is probably a thrombosis. Now we thought it is only a superior vena cava, SV subsection is causing problem, superior mesenteric artery. But what is the cause? Is it diabetes itself or something else? Then we measured the homocysteine level. Hyperhomocysteemia is always associated with hyperinsulinemia, and which commonly we miss it. So we did the homocysteine level. It was elevated. Probably homocysteine, it increases the coagulation factors, increases the Hedgeman factor, increases the platelet activation, and platelet activation results thrombosis. Probably the diabetic patients in uncontrolled diabetes are already having thrombotic stroke, ischemic stroke, and this one is causing probably all together and developed this
Did the patient go home?
Yes, sir.
Did the patient go home?
Yeah, patient saved. Now 2 years now is coming for follow-up.
So that's very good, because if it had taken this long to diagnose,
Yes.
the mortality is very, very high. That's why.
I think we thank you for really highlighting, starting with the case of EKA, how you have proceeded with respect to evaluation of the persistent abdominal pain in spite of resolution of the ketoacidosis. That calls for an workup. You went through the differential diagnosis so beautifully, and probably, yes, we were discussing imaging and all. Maybe in the temporal sequence, it could have taken a preponderance, but at the end of the day, you have done such a good work, identified the basic problem, and the patient is now doing well. Congratulations and thank you so much.
Thank you very much.
Dr. Moses, you want to sum up that?
I think I'm sure all of you would have enjoyed 5 different presentations, absolutely no agenda, and everybody was clueless about what they are going to present, and we absolutely. So I hope you did have a good session. We learned a few things, and thank you so much.
5 மணிக்கு மேலே